let's kick off. Yeah, so I wanted to start off with a more kind of introductory session before we get into the clinical stuff, as we sort of progress through the year. The idea this time round is to have a bit more of a curriculum. So I've sort of set up a spreadsheet myself of like the different subspecialties and the things that I want to touch on throughout. And I figured at the start of the year, sometimes, especially the junior trainees, the thing that they sort of worry about the most is the surgery and how to sort of make the most of their time. Some of you may have one cataract list, some of you may have two, some of you may even have three, and some of you may not even have a specific cataract list. So the idea is to try and figure out how to make the most of the theatre time. And as you progress as well, people still do have questions about what or how they can make the most of it when they're actually a bit more advanced, because you might start to think that the only thing you're really getting out of theatre time is actually operating. And I don't necessarily agree with that. So we're also going to start recording these sessions. The idea is to just record them. I will be uploading them pretty much raw footage to YouTube, because I am not a YouTuber and I will not sit here and edit videos because I cannot be bothered. So the idea is just to sort of make them available as a sort of free online library for people when they want to get back to it. We'll cover all sorts of things. I plan to cover the exams, clinical stuff. I've got a whole hard drive of cataract surgery of my own videos that we can go through at some point as well. So we've got a lot to go through. At the end of this, if there's any ST1s or 2s about who had some Q&A, I usually stop the recording and then we can have a bit of a Q&A. So let's kick off. So making the most of theatre time for cataract surgery. So I'm going to sort of touch on like both what I think is useful for you if you're a beginner in terms of being an ST1 or even potentially early ST2. And then I'm also going to touch on what I found useful as I sort of started my ST3 last year. Once I had, you know, a couple hundred cataracts under the belt, it became a bit more about how you actually see the list as a whole, and how you sort of go from being, you know, your sort of, you know, pick and mix in terms of nitpicking which cases you would do to actually starting to try and think of the list as your list. So your theatre session, we all kind of know what it's like. You sort of turn up, you've got no idea whether or not there's another trainee with you a lot of the time. It might be you and a couple of other people. Sometimes, depending on where you work, you've got no idea what's on your list before you get there because things change last minute. And the idea is to have this session as a sort of a bit of an approach as to how you can try and make the most out of it, because some people may only have the one a week. Some people will have one every like alternate weeks, for example, and they do feel like they want to try and maximize what they're getting out of their theatre session. People always seem to see cataract numbers as the be all and end all for whether or not they're good surgeons. And while there is truth in that, I'm not the kind of person who's going to tell you numbers aren't everything. I do think numbers are important. I still think that it's, you know, having 100 under your belt may make you a wildly different surgeon to somebody else who has 100 under their belt, and that could be in a good way or a bad way. And actually a lot of that is about what you've done before, during and after the surgery, rather than the actual case itself. Anyone can hack their way through a cataract. The idea is to actually, you know, be an efficient and safe surgeon, even if you don't have that many under your belt, which is very, very possible. And a lot of that comes from what you're doing around the actual case rather than the case itself. And I think it requires a bit more reflection than I think people give it credit. So we'll kick off with the before surgery. Now, a lot of this might seem really sort of obvious, but I actually think it's more important than people, again, consider, because they turn up on the day and if they haven't prepped the list properly, you might come across a lot of surprises, and then suddenly you're left quite disappointed. Now, a lot of this is not necessarily about just, you know, preparing the list, because if you're a junior trainee, someone else probably has, and you're unlikely going to be relied upon as the sole source of preparation if you're the only person on the list and you're an ST1. But nonetheless, it's about feeling confident enough to be able to tell the consultant what you think you can and can't do. It's about sort of presenting yourself properly to the team to then say, listen, I've done my homework and I think I deserve to sort of get involved. And at the end of the day, that is someone's eye. And I just feel like if you're just turning up on the day and you're seeing these cases as just numbers on your logbook, I just don't think that's particularly fair to the patient on the table, especially when you're a junior trainee. You can mess up, you can do things less than perfectly, and that's a person's life that has changed. And for you, it's a it's a point on your logbook, and it's a quick reflection that you're going to upload to your ARCP. I don't think it's fair for you to not prepare adequately before the list and know your patients properly. A lot of the way that the UK is going basically means that your patients will not be people that you've listed, and so you don't know how well they've been listed, which then means the information that's on the listing is sometimes pretty much nothing, and the patient is a diabetic who's had a previous vitrectomy, has a white cataract, and also just happens to have an axial length of 707. So then you're basically left saying, right, well, I can't do that, can I? But you didn't know because you didn't bother looking through the case. And it's also might be a case that your own consultant isn't particularly happy is on there. So it's worth doing this because it avoids hiccups on the day as much as possible, although sometimes things are unavoidable. But it also means that you're presenting yourself in a light that basically suggests that you care. And I think the easiest way or the best way for you to actually get hands-on experience is by showing that you care. So primarily look at who's on the list. So for each patient, what I always think about and what I'm looking at when I'm looking at the list is the patient itself. So the age of the patient, are they a 97-year-old who's got a single zonule, just sort of trying its absolute best to keep its bag where it is? Is it someone who's particularly young, who's likely to be a bit more fidgety, who's likely to be a bit more nervous about the surgery? Are they able to lie flat? Is that something that has been documented, or is it something that's been flagged as an issue? Do they have any breathing difficulties, any COPD? What medications are they on? Are these patients who are on something like alpha blockers, for example, who are going to make your iris very, very annoying? And actually, sometimes even if the iris is well dilated, you're still going to have sometimes issues when the iris sort of collapses, and we can touch on that when we talk about cataract surgery. Is the patient particularly anxious? Is it their first eye or their second eye? If it's their second eye, sometimes that's a slight relief because it means the patient's already been through it, and you can sort of rely on the patient to be a bit more sort of aware of what's going on. A lot of the time, people overplay cataract surgery in their head, even though it's, in my opinion, I actually think it has the potential to be pretty much the most complex surgery in ophthalmology, but then I am an S24, so what do I know? But it can go from something very routine to an absolute car crash really, really quickly. But nonetheless, patients still overplay it in their heads in terms of what's actually physically involved. And when they come in for their second eye, they're a bit more sort of, oh, actually, I know what's going on, so don't worry, which means they're automatically slightly less anxious. But it could also mean that their first eye was an absolute car crash, in which case they are somebody who is less likely to be very happy about a trainee doing it. So that's useful information to have. Then I sort of think about the eye itself. So is it a patient who has had previous surgery? Do they have glaucoma? Do they have any sort of lid issues? Have they had previous strabismus surgery, for example? Is their conj going to be a bit of a problem? Have they had previous glaucoma surgery? Do they have a tube in place? Do they have a trabeculectomy? What drops are they on? Because that tells you about the ocular surface. That information is quite handy to know. And then the cataract itself. So what kind of cataract is it? And then I sort of put this within the cataract. The axial length of the patient is useful to know before you've gone in. The anterior chamber depth, and then the lens choice is always useful to have before you've gone into surgery, because then you can sort of jig things around if you need to, and you also know what the refractive aim of the patient is, because the last thing that you need is somebody turning up on the day and changing their mind about whether or not they want emetropia or low myopia. The anesthetic choice is also handy. Some of this might depend on where you work. Some places pretty much do a subtenon for absolutely everybody. Some places operate on topical. It might be a patient who's opted for GA for whatever reason. So it's useful to be aware of what the anesthetic choice is before you go in. Now, I know it's really cliche for me to put this failing to prepare and preparing to fail thing. I always sort of roll my eyes whenever somebody has a quote on a slide, and it's just very hypocritical for me to put that there. But that really is like so true when it comes to cataract surgery. If you've been around for as long as 2 months, you probably already know about turning up on the day and there being so many unexpected variables. And it's really quite handy to have gone through the list if you can beforehand, because it means if things need cancelling, you can ask your secretaries to swap patients. If you're suddenly on a list where it's just yourself and the consultant, and they've decided to just book loads of red cases, you can basically flag that a bit early and then say, can we swap these out for some green cases so I can operate? So it is really handy to do that. Now, for the junior trainees, the reason you're doing this is to basically pick the 1 or 2 cases on a list, depending on where you're working, that you are going to do, especially if it's your first few cases and it's about kind of which ones do I think I can get my hands on. For the more senior trainees, for the ones who are sort of already kind of, listen, a green case is fine, I'm actually now thinking of the more complex ones, that's what you're sort of thinking about. You're sort of kind of going, is there, are there red flags that I need to think about that will be handy for the brief, that will be handy for me to consider and prep for? But also, which of these cases do I want to sort of warm up mentally and sort of say, listen, there's a white cataract on the list, I want to try and do that. And the idea is to sort of flag that early, let the consultant know, and sort of work around trying to do that. So it's really useful, really, for the both of you, whatever perspective you're coming in from, to prepare your list adequately. For the more senior trainees as well, you're sometimes by yourself. There may be a consultant on leave, and you may be signed off on allowing on being allowed to sort of cover a list. And if that is definitely the case, then the last thing you want is to be turning up on the day and it's basically just a list of brunescence and you're by yourself, because even though you can do them, you really can't be asked for that sort of risk when there's no consultant in the room, and it sort of looks a bit bad if then something bad happens. So this is incredibly important. And it just means on the day there's less anxiety about what's happening, which then means you're more likely allowed to be allowed to do stuff. Because especially when you're very junior, if you turn up and the consultant's already a bit pissed off, they're less likely to then also want a hiccup during the actual operating. So this is really important. Now, on the day, again, it seems really basic, but I think there are things that you should try and definitely do if you're going to then try and also get as much operating time as possible. Consenting the patients yourself on the day and introducing yourself on the day makes it much easier for the patient to just sort of quietly lie down and let you operate. If it's somebody that they've never seen before, they're obviously understandably going to be very anxious. So even just popping out and saying, hi, hello, I'm going to be your surgeon today, how are you doing? I will see you inside, that might be all you need to do. But I definitely think it's worth doing. The briefing, again, it depends on the boss that you're working with. Some bosses like to just do the briefing themselves, but I think it's a useful skill to have, especially for the senior trainees, to actually start leading the briefing yourself. Instead, talking through the cases, basically saying this one will need vision blue, this one might need a heel on GV, this one I need an insulin syringe, this one whatever, and then also talking about the kit that you're going to require with the nurses. Letting the nurses know whether or not you use a keratome, an MVR, an insulin syringe, a 27-gauge cystotome, a Rexis forceps, a bimanual, a coaxial, letting them know what you use early helps. And it also, again, presents you as somebody who has thought about their surgery, who has thought about what they want to be doing, and is more likely to be allowed to do stuff. Sometimes your nurses can be your best friends or your worst enemies in theatre. If you are somebody who they find is slowing them down on an already stressful job, then they may whisper in the boss's ear and make it very difficult for them to let you operate. So having them on side is very, very handy. Now, when it comes to your cases, consider what phaco settings you're using. Now, I'm not going to name names, but I'm going to sit here and be like, oh, you need to know exactly what number aspiration you are, or any of this bullshit. You're obviously going to use the settings that your boss is going to be using, which is fine, but know what they are, or at least having played with them, or like ask your boss if there's anything different about how the way they do it compared to your usual settings. Sometimes you might work somewhere that has a trainee setting specifically, maybe use that instead. The real differences is some people might prefer slightly more phaco power, some people might prefer a bit more aspiration, and just knowing that means you just can be a bit more careful. I'm going to come back to recording because this is the thing that I think is the most important. And then your supervision, the level of supervision that you want might vary case to case. If you're somebody who's already done a couple of hundred, you may just be okay to just carry on. And then you want somebody sort of a bit closer to you for the more complex cases. But for someone who's a bit more junior, you might actually want the person scrubbed up and ready at the microscope with you to talk you through all the cases. And there's nothing wrong with being honest about the level of supervision that you want. There's still something to gain from watching other people operate. Now, you're either going to be watching the consultant operate or you're going to be watching another trainee. When it comes to the consultant, consider why it is that the consultant's doing it. Is it because there's something specific about the cataract that means you need slightly more experienced hands? Or is it because you have a patient who requires someone who is a consultant to do it because they're more likely to be interesting in the post-operative period? And that's a valid reason for you not to do it. Believe me, you will have plenty of opportunities to operate, and you just need one awful experience to just make your life a nightmare. So just if it's someone who looks like they're going to maybe be a bit difficult, just avoid it. You don't have to yet. Pick that up later in your life. Have actually recorded my consultants operating. I usually take one case per consultant to just watch it back and see how they do things. You obviously ask them for permission, but yeah, I do that. And I also watch closely to how they actually operate. They may have a different style to you. They may do something a bit different to you. And it might be someone who makes you do everything the way they do it. If it's someone who lets you do your own thing, then it might be useful to watch how they operate because there might be something that you might want to pick up. With another trainee, again, this is a trainee who's had different bosses to you. This is someone who's had different experiences to you. So again, they may do things a bit differently. And while I'm not asking you to necessarily verbalize this, it can actually be handy in your head to jot down what you think the trainee does well and what they don't do well, because it might also reflect in your own surgery. If there's something that you think you're slightly better at, reflect on why you think you're slightly better at it. Or if there's something that you think the trainee is better at you at, then consider again what the trainee is doing to make that step better than the way you're doing it. I remember when I was a junior trainee, some of what I learned actually came from the ST4 that I was with when I was an ST1. Watching how they do things and how they operate, having a trainee sometimes give you their perspective because they're a bit closer to being someone who could never do a cataract operation. You know, you might be with a consultant who's been a consultant for 15 years, and even if they do train juniors, it's still different to having someone who only 3 years ago, 4 years ago couldn't operate. And now you look at them and you're like, well, you could do everything. So it's useful actually to have a trainee with you or to at least discuss things with your trainee. Now, with the nurses, the changeover between patients can be really helpful. Again, if you're speeding things up, then you're more likely to operate. And I know that sounds like it sounds very transactional, but it is what it is. If it's half an hour, if it takes half an hour to get the next patient in the room and you've got 8 on the list and it's taking you 30 minutes to operate, you're not going to be allowed to do very much. Whereas if you're helping that changeover process be a bit quicker, then there's more time to let you get stuck in. If there's additional equipment that's required, help them out, pick something up, or for example, just let the nurses know and preempt it. So for example, before your case, while the consultant's operating, you just let them know, by the way, I'm doing the next one. Could I have this, this, and this? And everything's ready for you to operate, to do it when you're operating, because when you're actually operating, having to also worry about what's on the table is just unnecessary stress. So consider that. And then in terms of your scrubbing, for example, make sure you're scrubbing on time, blah, blah, blah. And all of this just helps makes things a bit more efficient. Now, recording your cases is what I wanted to go back to. I genuinely think this is probably one of the most important ways that you can learn from your own surgery. You will forget almost immediately how the case went, unless it's been an absolute car crash. And watching back your cases, I actually think is really helpful. And I don't care how nerdish that sounds. I genuinely think it's really helpful. It's also helpful when the case went well versus when the case didn't well. What? Versus when the case doesn't go well. Because actually for the cases that go well, watching back how you did it helps. Noting when you started pivoting the cystotome, when you pivoted for the rexus, for example, how you cracked, where you positioned your chopper, what you did when you were removing the SLM. When things went really smoothly, you may forget why they went smoothly, especially in the early stages. And watching back those recordings is really helpful. I still record every single case. I will go home, I will flick through every single case, and I'll just delete the ones where nothing interesting happened. And I will keep the ones where either something went really well because you use it to show off, or you're using the ones where you have the ones that have, like, I have a hard drive now of like the sort of messier cases, the tricky cases where, did I use hooks? Did I use a ring? Did I use a CTR? Was it a white cataract? Was it a small pupil? I have that as a sort of library of stuff. Now, you may not need that. You may not be the kind of person who wants a library of things. You may not be the kind of person who's doing a lot of teaching. That's fine. I still think it's worth watching it back and then just deleting if you don't want it. Because you never know what's going to happen on the day. I had a patient, I was so pissed off the one time I wasn't recording. I had a patient go into aqueous misdirection during my surgery, which was quite cool. in terms of the microscope, and we were able to sort of sort everything out. But I don't have the recording, so I don't have that as in my kind of repertoire. So it is very, very useful to record. And in terms of after the surgery, there's a reason why I think those recordings are important. So feedback on the day. Getting feedback from the consultant is really important. If they're the kind of consultant who's not giving you much feedback, then your recordings are where it's helpful to then go to a consultant who might. And the other trainee, if they're in the room, if they're a senior trainee, it can actually be pretty handy to get the feedback from them. I take feedback from either the senior trainees and sometimes even the junior trainees, because these people have watched other people operate. They have something to compare to, and they are helpful to basically let you know how you're doing, I think. And they're also useful to bounce ideas off in terms of, oh, I saw this is how you were doing the Rexis. Why did you do it that way? Here's how I do it. And the patient sometimes just, I'm not asking you to sort of get them up and be like, how did I do? But the patients will sometimes give you feedback in terms of how you made them feel and how the actual operation felt. And sometimes it's handy to sort of reflect on that sort of thing. The recordings, again, like I said, so watching them back, I think is super important. And I have, especially when I was in ST1 and 2, I did watch the recordings back with a senior that I trusted. So with a consultant who, offered me the time and was more of a sort of mentor relationship. They were very kind in sort of offering me the time and actually sitting down and looking through the recordings. When complications happen, this is also super helpful, because actually a lot of the time, when the PCR happens, you didn't necessarily catch when it happened during the operation. And then afterwards, you go back, you have the recording, you can sit back and you can actually look back and see, what was your phaco probe doing? Where was your chopper? How did you come out the eye? And that can actually help you pinpoint exactly where the PCR happened and what to do differently the next time. And follow up your own patients. I think if something interesting happened, you definitely need to be following up your patient. Just look up the notes if you're not the one seeing them. And depending on where you are, this is sort of trickier or not so tricky. If you're somewhere that has open eyes, then actually that can pull refractive results for you, which is phenomenal, because it means you don't need to do anything. And you just click a button and then it gives you like a little graph of how far you are from your refractive aim and what your VA results are. Later on in your training, as you progress, you will need to audit your own results anyway. But I still think it is helpful to have an idea of how you're doing. Now, when you're very junior, no, I'm not expecting an ST1 to sit here and look up all of their patients and how they're doing, because actually a lot of this depends on the lens choice that you're making and what refractive aim you're aiming for. Some people aim for -1/3, some people aim for as close as possible to 0. So it depends on what you're doing, and a lot of that will depend on your boss in the junior stages. But I still think it's helpful to be following up your patients in terms of refractive results as well, just to see how things are landing. Okay. Now, how to train sort of outside of cataract surgery is something that I've always been asked. So simulation, if you have an ISI nearby, you will almost, I think as an ST1 now, you pretty much have to complete all the modules, I think, by the end of ST1. The Rexis is probably the most useful part of that, but you still have to do it. And like phaco courses and complex phaco courses that you can go on can be really handy, because sometimes when you have a complex case and then you're sort of looking at the consultant being like, oh, this one might need hooks, and they sort of tell you, have you ever done one? And you kind of go, I'm not even entirely sure what they look like, then it's unlikely that you are going to be allowed to do it. So going to these courses where you've at least seen what a hook looks like, seen what a ring looks like, know how a Malyugan actually comes out of the handle thing, and have a general idea of how these things are supposed to work, I think that's handy when you are then having to face these things in real life. Now, the other thing that I did, which was sort of maybe revealing how much of a loser I was when I was an ST1, but motor memory actually really helps. So I was finding, like, on my commute, like on the train, for example, or even just in bed, I would basically pretend I'm doing a cataract operation with my hands. And actually, it turns out that that's actually like a valid way of like trying to develop muscle memory. So like I was looking into this, like F1 drivers sort of like basically pretend that they're driving through the entire track in their heads. And I actually did find it helped, like practicing with my hands, just doing the movement of what I'm doing with my left hand when I'm using the chopper, what I'm doing with the right hand when I'm phacoing, how I'm actually doing the rexis. I actually found doing that was quite helpful because it meant even if I wasn't operating, I was still moving my hands in that sort of way, which then meant that if I had a couple of weeks off as an ST1, which sometimes meant that you were basically coming back as a beginner, it still meant that my hands were sort of kind of making those movements. I've already spoken about recordings. I'm not going to exhaust you again with that, but please, please, please record. I do think it's helpful, even if you're not saving them. And sometimes just watching videos online. If you've not seen a white cataract, you've not had one come across on your lists, if you've not seen a brunescent, if you've not seen a small pupil, again, it's about just seeing how these things have been managed in the past, because then you can gain much more than you think from just watching it, because at least when you're then having to do it, it's not the first time you've even seen how these things behave. Seeing how a white cataract behaves when you're chopping it, seeing how brittle it can be with a properly cortical white cataract versus a sort of white intumescent or like white brunescent where it's a bit leathery, and actually when you're trying to crack it, it doesn't really crack. It sort of there are fibers that sort of almost hold the heminucleus together. So seeing how these things behave, even just once before you're having to do it, is very helpful, because you're not seeing these things for the first time when you're actually looking down the microscope. And then obviously actual surgery, again, I just don't think anything beats that. You need to be operating, and if you're not, you need to flag it. People will try and tell you that numbers don't matter, and then suddenly you're an ST4 with fewer than 200 cases. I don't think that's good enough. It might be different around the world, but the point is it's not here. And I think pretty quickly you're suddenly being seen by your grade, and if you're not able to do certain things, then again you're going to have opportunities withheld from you. So I think it's important to have numbers under your belt, and I'm saying that as a trainee. Maybe come back to me in 10 years and I'll tell you I don't. When I have 1,000 cases a year, then obviously I'm going to be telling you numbers don't matter. But I do think it is worth having a part of you that is semi-chasing cases, especially in the early stages, because that's what ultimately is going to help you operate. Nothing beats actual surgery. So do try and push to get your opportunities. And if you're not getting them, do flag them, let your bosses know, and see if anything can be done, because I don't think anything beats that. That pretty much brings us to the end of, like I said, it wasn't going to be particularly long. I just wanted to sort of touch on what I think can make the most out of cataract, your time in theatre, and then we'll gradually be sort of getting into more clinical stuff. I'm going to be doing a session for people sitting the part 2 oral on strabismus, which I will also let all of you guys know, because it is basically just a clinical strab session. So we'll kick off with that. That will probably be this Saturday sometime in the morning, or maybe Sunday, but I will let you know the timings. And again, we're going to be recording this stuff and uploading it all to YouTube. So thanks for coming. Please do scan this feedback form. I know all of this is for free. I'm not getting anything out of this, but the feedback is helpful. A, it helps me sort of know how I'm pitching this stuff, and B, I'm going to be completely honest with you, it does help me, because then it shows that I've been doing some teaching. It's not the reason I'm doing it. I promise you it's not. But it is helpful. So please, please, please do. I'm going to stop recording. And then if people have questions and stuff like that, then that can happen without the recording. So I'll stop now.